I think what I was going to talk about was just something on a sort of trying to sort of have some broader view on trials from my perspective. Now, it can be challenging of sort of how I construct this, but it was just some thoughts in terms of what do trials mean for me. So treating from a doctor's perspective or from my perspective, like most people, I do have some disclosures in that I work with a number of pharmaceutical industry representatives, and these are my immediate disclosures, but none of this is dependent on any of those. This is my thoughts rather than any of their thoughts. So this is just a schematic that looks at the evolution of CLL treatment over the last 50 years. What we can see from here is that when there's been relatively slow development, and this is just sort of shown as a cartoon in terms of at the beginning on the left, chlorambucil still used occasionally, actually first introduced in the mid-1950s with or without steroids. And this slow evolution of treatment that went on for the next 40 years. The sort of annus mirabilis, if there was going to be one in CLL, probably occurred around 2014, which was the marked by the licensing of ibrutinib. And this is really, since then, has been marked this transformation. If we look backwards, well, we did make quite a lot of progress. I mean, I think if you come back, FCR, we're still using FCR, the state of the art of the mid-2000s. It's something that works. Trials really changed. So previously, if we go backwards, we compared two drugs, A versus B. B was a bit better. B versus C, they were the same. C versus D, D was better. And trials changed about every 10 years. Post 2014, this huge influx of new therapies coming through. And I think that one of the things from a trial perspective, it's meant that we've got a lot of data coming through in real time. And so as a clinician, one of the real challenges is knowing how we interpret that, because we have data coming on top of data. Thankfully for CLL, the bar's pretty high. FCR chemotherapy offers response rates of 95% and remission durations measured average in 6 years. So it takes quite a long time for us to see how things unwind, let alone when we've got more treatments coming on top of it. And this is only just a real snapshot. There are, of course, other therapies. This is not a comprehensive list. So one of the immediate challenges is how we can use this, how we can use new treatments. Do we use them instead of chemotherapy as well as chemotherapy? Do we use them on their own? Do we use them together? And most importantly, how we sequence therapy. So just coming back to a patient question, I sort of like to come back, because patients is about what I'm doing here is trying to treat. And so coming back to a patient, so this is somebody I treated relatively recently, a 69-year-old man. He, like most people with CLL, was diagnosed incidentally a number of years ago with a lymphocytosis. He was working abroad at that stage and just managed with active surveillance or watch and wait, and was very well. He then went to see his hematologist locally, noted that he was becoming a bit more anemic. His lymphocyte doubling time was shortening. He'd got some lymphadenopathy, and this is what's shown in the arrow. It's a big lymph node mass adjacent to his pancreas, which sits just over here. Quite a lot of lymph nodes, and he was becoming more tired. Of note, he'd had some issues with his heart, had diabetes, and his kidney function was slightly impaired for reasons unclear. So the question then is what to do with him? Well, it may be, it's a self-evident thing. Let's look at what trial data show us. So if we look at a trial, this is a study that was published a couple of years ago. So you'll be aware in the UK that we're still running the FLAIR trial, which is anticipated to end at the beginning of next year, which is comparing FCR with ibrutinib. There are 2 trials in the US that have now completed addressing similar questions. This was a study run by the Alliance Group comparing bendamustine and rituximab. It was aimed for people with comorbidities, with ibrutinib plus or minus rituximab. And what did this trial tell us? Well, this trial told us that if we looked at progression-free survival, so those people, these are Kaplan-Meier charts, and I guess many of you will be familiar with them, but for those who aren't, what does this tell us? Well, everyone starts at the beginning alive and in remission, and every time somebody either progresses or they die, then the curve drops a point. And so as you get down to here, at the bottom, if everybody died, then it would get down to 0. And so what you can see from this is that proportionally a significant, over that 4-year time scale, a lot more patients with bendamustine and rituximab had either progressed or died compared to either those treated with ibrutinib. It tells us that ibrutinib and rituximab doesn't really seem to make a difference because the curves overlap, but it suggests that ibrutinib on the basis of time to progression is much better. So we should just carry on and treat people with ibrutinib. Maybe that's what we should be doing. New is better, ibrutinib is available, let's just treat with ibrutinib. Is that the end of FCR? Well, I think from my perspective, it's all a bit more nuanced than this, and we need to think about how we interpret trial data, because this is some data that's come from 3 trials or 3 studies that were done quite a number of years ago now, and this is looking at the outcome of selected people treated with FCR. FCR is the state of the art of 2004, but is it bad treatment? And you can see from this, if we define patients as having good risk disease, this is mutated IGHV sequences and no adverse karyotypes, so no evidence of P53 or ATM deletions. It's a subset of patients. These do extraordinarily well with FCR, and some of the data is indicating that after 12, 13, 15 years, the majority of these people are still in remission. And so 6 months of chemotherapy with a 15-year survival and the potential for cure, not a bad outcome. And I would suggest that we shouldn't be, if we're doing trials, assuming that new is better and leaving things behind. We need to be individualizing our therapy and not just assuming that all of these new therapies will replace what was there in the past. The other thing we need to be aware of is toxicity. Ibrutinib, for those, I'm sure people in the audience are taking ibrutinib. I think the data that we saw from the original trials, for somebody who's had 10 lines of therapy and is on ibrutinib, toxicity has really become less of an issue because of the fact that there's nowhere else to go. And this was seen in the original trials. It was very well tolerated and nobody stopped it because of the fact that if they stopped it, disease would progress. As ibrutinib has worked its way back into frontline therapy, we are starting to see what the real toxicity is. So this study, this chart here, it shows 5 columns, and this is looking at experience of treating patients with ibrutinib, predominantly in relapsed disease. So, and the PCYC, that's from 2 trials, Ohio State, the OHSU, MD Anderson, 2 big US centers, the Resonate trial, which was comparing ibrutinib and ofatumumab, and then some real world US data. And what this demonstrates here is that somewhere between 10% and 40% of patients on ibrutinib in the US discontinue their treatment. And the reason they discontinue their treatment is not because they can't afford it, it's because of toxicity. And so it is something, I think, that it appears to depend very much on the line of therapy. So greater discontinuation rates seen earlier in disease. So it's fine to be taking a treatment for a while, but we know that particularly for people with untreated disease, it's quite a chore taking therapies and taking them long term. So just to question this sort of idea, is new necessarily better? One of the questions we need to address and really be thinking about how we interpret trial data. What about getting to trials? I mean, I think that one of the questions that Brian had posed at the beginning is why don't more people go into trials, or what stops them going to them? Because it's the way that we make progress. CLL therapy has advanced by being able to do trials. And what is it that stops people? And there are a number of reasons whereby people who may be eligible for trials don't get there. This was a study that was done a number of years ago. It's not related to CLL. It's not even a hematology. This is looking at cancer trials, and it's in the United States. And I would emphasize the fact that US practice is very different to that in the UK. A lot of community oncologists don't necessarily put people into trials. There are also funding constraints because nobody gets paid if they go. And if you're working in a healthcare system whereby you get paid by treating people, then that's a disincentive. But reasons, and I think it's I don't know whether it's surprising or not, but what were the reasons whereby people didn't go into trials? In 4 broad groups. The first was access. So is a trial available in the clinic? And this is half of it. And I think that this is something that certainly does resonate in the UK. We don't have a good means of being able to ensure that people have got equitable access to trials. We try to open them broadly. So the FLAIR trial, for example, is open in more than 80 centres around the UK to make sure that people do have access. But certainly in terms of later stage later stages of therapy or some of the smaller commercial trials, it's actually quite difficult to find out where they're available. Not everybody's eligible for trials. This is one of the things. Trials are very prescriptive. You need to be to tick all the boxes, and this can certainly plague it. It doesn't have the wriggle room that you have with routine clinical practice. We've got physician problems. Some physicians don't believe in trials, or they don't offer it, or they will sell a trial. Would you like to have my standard easy treatment, or would you like to travel 20 miles to the Christie to have a trial and you realize it's uncertain, it might kill you? I think, these sort of things, and this is being a bit facetious, but it depends a bit on who you're seeing. And then, of course, there's patients' attitudes as well. As patients, you are all the people who will be deciding whether you wish to go into the trial. But I think it's, this shows that the majority of the reasons for not recruitment is not down to patients not being willing, it's due to a trial either not being offered or not being suitable. And we need to do things to make sure that the trials we have are applicable to CLL patients, and mindful of the fact trial populations tend to be very skewed. Young people go into trials. CLL is a disease of older adults, and often the trials are not available. So in terms of what's the standard approach, how have we approached trials? Well, these are some of the questions that have been raised in terms of thinking fit or non-fit, and I'll come back to this. What's the genetic or mutation, the risk factor? We use progression-free survival as an endpoint. And then the question is do you just treat forever and tolerance, or should you be giving time-limited treatment? And to try and answer some of these, I don't have answers to all of them. I think taking the first thing, fit or unfit. When I first started treating CLL 20 years ago, it was not that exciting to treat. It was mostly a disease of old men, statistically, and treated with not very effective therapy. There was more effective treatment with immunochemotherapy, but it wasn't applicable to the majority. And I think this distinction is something that is really just going into history now. Many of the newer treatments are equally applicable to older people, people with comorbidities, and we need to drop this distinction, this artificial distinction in trials, and be thinking about making the trials applicable to as many people as we can do, mindful of the demographics of the disease. This is not a disease that's predominantly seen in young people. We need to be thinking about doing things in a more clever way. So as many of you or all of you will know, there's a significant impact of p53 dysregulation. So p53 is a protein that's mutated in many cancers. And the reason p53 is important is that p53 is one of the things that you have to switch on when you're treated with chemotherapy for a cell to die. Chemotherapy is not like Domestos. It doesn't just burst the cell. What it does is it causes the cell to want to die. And one of the ways it does that is by activating p53. So if p53 is not there, it's deleted or it's mutated, then chemotherapy doesn't work very well. And these are just two survival curves. Again, this is taken from two trials. I'll just go through one of them. So this is looking on the left. This is the CLL trials. This is a German trial, number of years old now, comparing FC and FCR chemotherapy. The green lines, for people are for people who don't have p53 mutation or deletion. So proportionally over the 10 years that they were seen, more of the patients at the end of there were either in remission and alive. Those who had p53 deletions or mutations, significantly worse outcomes. The right is the RESONATE trials. This is for relapsed patients treated with ibrutinib. And you can see on here that the difference between them is less, but there is still a distinction. So ibrutinib adds to what we have for treating people with p53 dysregulation. It works better than chemotherapy, but it's still not perfect. And this is just one example of what we can use and what we should be using and will be using in trials to try and unpick how it is that we can individualize our therapy based on the fact of what's there at the beginning. So CLL is a genetic disorder. It's not one that we're born with. It's not one that you pass on, but there are different genetic mutations that can cause the same disease, but they underpin why some people will do well, why some people will do less well. And this is just an example of a publication that was looking at some of these factors and how these things cluster. So we can just use, as well as using p53, and if we take each line, this is looking at a group of patients, all the patients on the top line, it's looking at their immunoglobulin heavy chain sequence, and then looking at a range of other abnormalities. You'll see p53 mutated on the third line, deletion of 17p on the fourth line, other abnormalities are shown. And you can see that you can start to find groupings of disease, but it's not just about P53. So what we can see is there are also some of these other mutations, so SF3B1, notch mutations, other things that tend to can be associated with a poor prognosis, that we also potentially could target therapeutically or identify those people who weren't going to do very well with standard treatments. The technology is there to do these tests. The problem is how you interpret the data and what you do with it. But I think we will be seeing a lot more of this in trials coming forward. It's very important that we do the right trials and that we also choose the right endpoint. So moving aside from how we enter into trial, what are we going to choose as the endpoint? Well, and this comes back to also while we're going to do the right trial, it's a challenge to the pharmaceutical industry really, is that it's very easy to do a trial comparing a drug to something that doesn't work very well. Perhaps the best example of this was a study that was finished a number of years ago, which compared idelalisib, a drug that showed a lot of promise but somewhat out of fashion due to toxicity, with rituximab. And not surprisingly, again, another one of these Kaplan-Meier charts, patients who were treated with idelalisib did hugely better with rituximab. The problem here is rituximab monotherapy has been known for years to not be effective treatment in CLL. That was established in about 2000. And the slightly, I don't know, mealy-mouthed explanation given was that it was approved and it was commonly used, but certainly not by anybody that I know. So I think when we look at trial data, we need to make sure, and I think it's going into a trial, what's the benefit of being in it? Because if you're going to get a comparator that isn't any good, well, okay, we might find that something's better, but what we need to be doing is making sure is equipoise, that we're comparing drugs against a valid comparator. And also that we're using the right endpoint. Progression-free survival is not a particularly useful endpoint in CLL. What I would like to achieve as a physician, I'm not a patient, but what I want to achieve is treatment that makes people live longer or cures their disease, so overall survival. I want to do that without getting significant toxicity. The good problem in CLL is that people do well with treatment and it takes years to see whether or not you see a benefit. Trials are very expensive and you often don't have years to wait. So consequently, both as investigators, as patients, as pharmaceutical payers, they want to know things before 10 years. They can't run a trial for that long. So progression-free survival is used as a surrogate endpoint. So it's something that's been largely constructed for the purposes of trials. But we know with CLL that many people progress. They can progress, but it can be many years before they actually need retreatment. So consequently, time to retreatment or overall survival might be better. What I think we'll see a lot more of, though, is using minimal residual disease, which again, many of you may be familiar with, as a better surrogate endpoint. So minimal residual disease is just a means of defining remission. So a standard remission test might have a sensitivity of 1 in 100 cells. So you can be in remission and have billions of leukemia cells left. Minimal residual disease takes that down to 1 in 10,000, or with newer technology, 1 in 100,000. And we know that if you look at the impact of minimal residual disease, those people who achieve MRD negativity, as Robin's already told you, do better. And we can see this in terms of that MRD appears to be a good thing irrespective of the trial that's done. So this was a retrospective analysis done in Leeds, where they looked at the impact of MRD negativity on outcomes. This was without reference to whichever treatment you have. And you can see here that for both progression-free survival and, more importantly, overall survival, those patients who were treated who achieved MRD negativity had a much better chance of both having a longer survival in the context of both frontline treatments, they're previously untreated, and relapsed disease. So I think increasingly MRD is something that we'll be looking at as an endpoint that's probably more relevant than progression-free survival. And can you get to MRD negativity? Well, we've seen that, and this is just some data from the Clarity trial that Robin's already talked to you about. In terms of getting to MRD negativity. So the schematic here, just looking at the percentage of patients, this was an interim analysis. At the beginning in red, patients all had disease, so none of them were MRD negative, which is what you'd expect. As you go through the trial, getting to month 26, so 6 months into it, we saw here that the majority of patients were MRD negative, but this was done at different thresholds. So yellow, MRD negative with a relatively low sensitivity, the greens, MRD negative with a better depth of remission. But what we're seeing here, 40% of these patients achieving MRD negativity, some of them with a very deep remission. And its expectation is with this type of treatment, that depth of remission will translate into the remission duration. And so far, so good. With 2 years of follow-up, this was an interim analysis. Most patients at 2 years were alive and still in remission from their disease. So I think this is really intriguing data, particularly in the context of relapsed disease, seeing that we're achieving high rates of MRD negativity, high rates of progression-free survival. And I think this is really sort of shaping what we're going to be doing in terms of treatment going forward. So then lastly, should we be stopping treatment? One of the questions, I've come back to it earlier, is ibrutinib forever a really good idea? Or should we be stopping treatment? Is it a good idea to be taking treatment forever, which might lead to a selection pressure breeding out, and therefore you get resistant cells? And so one of the questions that's going to be posed in a trial that we hope very much would follow on from FLAIR, but due to some administrative reasons has been slower to get off the ground, but I hope this will be opening next year, static trial, which is going to be saying for those people coming out who've been treated with ibrutinib, they can continue with ibrutinib. Then we asked the question about whether or not, for those people that have responded very well, whether they continue with it or whether or not we stop and then re-treat them at the point whereby we see disease progression. And I think this is quite an important question because we're now seeing people who've had ibrutinib for many years, and so consequently the question then is, what do we do with them, after 6 years or after 10 years? Because there are both advantages to the patient, minimizing toxicity, but also we've got to think about the financial pressures. Ibrutinib costs tens of thousands of pounds a year. And then where next? Well, this is a likely schematic of where we may be going next. So this is a proposal that's still not done. This is the ERASE trial, which is the sort of where we're looking at working in terms of the next lot of CLL frontline therapy trials. So integrating some of the things that I've been looking at. So everyone at the beginning will have whole genome sequencing to identify actionable genetic mutations, seeing if we can really refine this question about how we treat people. We'll be using a backbone of venetoclax and obinutuzumab, which has been recently NICE approved as being our standard arm, and then comparing that to a BCL2 inhibitor and a BTK inhibitor. It probably won't be with venetoclax and ibrutinib, but will be with some newer next generation drugs, but similar, building on what we've seen from Clarity, and then using an MRD endpoint. So again, coming back to the things I've raised, genetic information is important, combinations of these new treatments which appear to be very powerful, and trying to achieve MRD negativity as our endpoint, which appears to be very important for the natural history of the disease. This is something that's still being worked up, but I think this is where we'll be looking going next with the treatment. And it's important in terms of costs. We've got to think about the costs. I don't pay for things, but costs are important. This was a US schematic of how much CLL will cost. So 2011, $180,000 over the patient's lifetime, now looking at somewhere upwards of $500,000 to $1 million. And clearly this is something that we've got to think about this because we have to make treatment affordable, but this is something that I'll have to leave into the hands of regulators and also the people that pay for it, which leads us on to my next talk. So I think coming back to summary, there are lots of new treatments. We need to do the right trials, and we need to think about making sure that we've got access to trials. I've given you a view on what the future may look like, but it is uncertain. But I think it's really exciting times with CLL of how we can integrate genetic information, new treatments, MRD endpoints. But we do have external factors, pharmaceutical industry, regulators and reimbursement, both are getting trials underway because they're expensive, and then being able to bring the new treatments into the clinic. So with that, I'll close, and I think that takes us neatly into the next presentation, which is coming back to the pharmaceutical view on this.